Okay, in this video we will be discussing about dermatomyositis. As we have already discussed in the previous video about inclusion body myositis, in this video we will be discussing about this. In the continuity, we will be discussing about dermatomyositis. See, there are many other inflammatory myopathies, right? Many other inflammatory myopathies like polymyositis, inclusion body myositis, immune mediated necrotizing myopathy, that is IMNM, that is typically seen with statins, right? And dermatomyositis. Particularly in this video, we will be restricting our discussion to dermatomyositis only. Okay, now moving on to the next slide. First of all, we will be discussing about the clinical features of dermatomyositis. Very important. We will be discussing with the help of images also, but as far as uh, mugging up is concerned, I think it is very important to learn the names of the signs. So, right. So first of all, we will see that dermatomyositis is a symmetric and proximal myopathy. Right. Proximal weakness, not myopathy. It is myositis. Proximal weakness. Proximal muscles are involved. Proximal means muscles of the shoulder girdle and hip girdle are involved. Proximal, big muscles are involved first of all. Right. After that, because it is dermatomyositis, signs pertaining to the skin are also there, are very prominent in this kind of myositis. First is the heliotrope rash, right? Heliotrope rash. Heliotrope rash means it is periorbital edema and periorbital discoloration of the eyelids and around the orbit. It will be darkened, discolored, purplish kind of skin. It is heliotrope rash, very characteristic and very commonly asked in the exams, right? Many times a question has been asked on this heliotrope rash. Then two very confusing names, one is the Gottron sign and second is the Gottron papule, though it is not confusing as far as names are concerned, because Gottron papule is a papule and sign is a sign. Gottron sign means it is erythematous rash, red colored rash over the extensor surfaces of the joints. Which joints? Knuckles, elbows, knees, and ankles. Mainly we see it on the knuckles. Papules are the same rash when it becomes papular, when it becomes raised above the surface of the skin. Then it becomes a papule and it is raised, right? Then there is V sign. It is anterior neck and chest, right? For example, this is a person. The anterior neck and chest, which is sun exposed, it will get involved. There will be a rash. Which kind of rash? Erythematous rash, right? Erythematous rash over this area. This is called as V sign, right? Sun exposed anterior neck and chest. Then there is shawl sign, a similar finding on the back of the neck and the shoulders, right? Shawl sign and V sign, Gottron sign and Gottron papule. This was a question which was asked in NEET SS, not in NEET PG, but NEET SS in 2023. Then there is nail bed changes. Nail bed telangiectasis means dilatation of the small vessels or capillaries around the nail bed. Then there are subcutaneous calcium deposits also. So these are the signs and symptoms of dermatomyositis. Remember, it is proximal, and there are a few named signs which we need to mug up. With the help of uh, images, if we see, this is the images, uh, particular images which are seen in depicting the signs of dermatomyositis. First is the macular erythema and plaques, Gottron sign. This is the macular erythema only. Macular. Macular means it is not raised. If it is not raised, it is Gottron sign. Once it is raised, it becomes papule. This is raised. It becomes papule. It becomes papule. it becomes okay. Gotrons papule, right? Gotrons papule, it is raised papule. Then on the elbow also, this is on the elbow basically. Macular erythema plaques over the anterior neck and chest, V sign. Let us see the V sign. Here is the V sign that we discussed previously in the previous slide also. This is a V sign. This is a shawl sign, and this is V sign, right? These are the nail bed telangiectasias, right? So these are some signs which we can see. This is basically a picture from Harrison's textbook. So very important to remember this. Then what we will see in the laboratory, I mean, what are the lab signs and symptoms? See, because it is a myositis, there is damage to the muscle fibers, so creatine kinase level, ck levels will be elevated. First of all, very very important to remember. Then the antibodies. One thing that is very important in any inflammatory myositis is particular antibodies that are pertaining to that kind of myositis. So it is very important to remember, because these antibodies are associated with certain extra extra muscular findings also. For example, in this case, in dermatomyositis, the anti-MDA5 antibody, it is associated with worse prognosis because it is rapidly progressive ILD. It is seen in ILD patients which are there in dermatomyositis. Then there is anti-TIF1 antibody, transcriptional intermediary factor 1. It is also associated with ILD, right? Then anti-Me2 antibody. It is basically benign disease and favorable prognosis. Anti-TIF1 antibodies are also associated with increased risk of cancer, right? Anti-NXP2 antibody is also increased with increased risk of cancer. So that is why it is very important to remember these antibodies, because they are associated with certain other findings which we need to know. Histopathology, very important. In histopathology, what we will find is that there is no invasion of muscle fibers as such by inflammatory infiltrates. What are inflammatory infiltrates? They are basically dendritic cells, macrophages, and some lymphocytes also. Very typical of this is, let me mark up in here. First of all, the stain that we use MXA protein, and this is MXA protein. It is seen as black discoloration where the inflammatory damage has been done, or inflammatory antibodies they are deposited. It is stained black, right? It is stained bright by MXA protein. Okay. Otherwise, on light microscopy, on H&E stain, we will see that the inflammatory infiltrate is basically perifascicular, right? Perimycial connective tissue. They are atrophic and basophilic, right? It is not invading the muscle. Let me zoom in. These are the muscle fibers, right? You can see the cells are not invading these muscles, but they are just perimycial. They are just around these muscles. They are extra in some space which is not these muscles, which is extra to these muscles, and that is the perimycial space. This is also the subperimycial space, right? So this is the Perivascular space, sorry, this is basically the pattern of involvement of muscle. Very important to understand कि the muscles are not invaded by the cells. The perimycial space, perivascular space is invaded, but muscle cells are not itself, are not themselves invaded. MXA protein, this is a special stain which is used for, particularly seeing the damage to the muscle fibers. How will you treat these patients? Very important, they are responsive to immunotherapy. In previous video, we discussed inclusion body myositis, IBM. In that kind of myositis, that was not responsive to immunotherapy. But very important to understand that dermatomyositis is responsive to immunotherapy. We give prednisolone 0.75 to 1 mg per kg per day. It is the first line of treatment. When do we add a second line treatment? When first line fails, we wait for 2 to 4 months. We give steroids and wait for 2 to 4 months. If it fails, then we have to start with the second line. Second line is methotrexate. Others are also, but we mainly use methotrexate. When there is some other organ involvement like ILD or myocarditis or myocardiopathy, then also we use second line, we add on the second line. When there is increased risk of steroids, we have to taper the steroids. For example, osteoporotic postmenopausal females, we have to taper the steroids in those individuals. So we have to replace the steroids with methotrexate, or we have to taper the dose and add methotrexate so that the side effects of steroids can be minimized. In these cases, we have to add a second line agent. Very important to understand. This is also very important, right? So this is the treatment of dermatomyositis. Prognosis. What is the prognosis? See, if there is no secondary or no associated illness, for example, if there is no ILD, if there is no cardiomyopathy, or if there is no risk of cancer, then the 5 year survival rate is very high. It is a good prognosis. It is a good sign. It is a good news. The patient can survive for 5 years. 93% of them can survive. But if there is increased age or ILD or cardiac disease or inadequate treatment, the prognosis is poor. Sometimes carcinoma, if it is associated, it is also a poor prognostic sign, right? So prognosis generally good. If associated other diseases, it can be poor, right? So that is all about dermatomyositis. Let us see once again. Uh, Among others, this is one of the inflammatory myositis. Clinical features: heliotrope rash, Gottron sign, Gottron papule, V sign, Scholl sign, nail bed, telangiectasia, and subcutaneous calcium deposits. Then are these are the signs which are given in Harrison's. You can see them or you can take a screenshot of this, right? Lab features: we have to know key CK levels are elevated and certain antibodies they are associated with certain other manifestations. We need to mark them up because they are repeatedly asked in the exams. Histopathology: perimycial perivascular involvement. Treatment: responsive to immunotherapy. It is a good news. We give prednisolone first of all. Prednisone means it is oral. Prednisone 0.75 to 1 milligram per kg per day, and we can add second line agents in some cases. Then prognosis, uh, it is basically good if there is no other associated illness. So that is all about dermatomyositis. Thank you for your patient listening.